In this section, we are going to discuss respiratory illnesses such as asthma, COPD, chronic bronchitis, emphysema, and pneumonia. Let's get started. What is asthma? Well, asthma is one of the most common chronic respiratory diseases in the world, but the mechanisms by which asthma attacks occur can be a little bit confusing. So the components of the asthma pathophysiology are irritation and inflammation in the airways. Muscle contractions can happen in the throat, and airway obstruction causes mucus to build up. There are two phases of asthma exacerbation. So these include the early phase and the late phase. And the early phase is initiated by IgE antibodies that are sensitized and released by plasma cells. So certain triggers in the environment are going to release plasma cells. IgE antibodies then bind to high affinity mast cells and basophils. And when a pollutant or risk factor gets inhaled, the mast cells release cytokines and eventually degranulate. And released from the mast cells are histamine, prostaglandins, and leukotrienes. So remember, IgE antibodies are initiated and they are released by plasma cells. And then from here, when a pollutant or a risk factor is inhaled, the mast cells release histamine, prostaglandins, and leukotrienes. So when the lungs are introduced to any contaminants or pollutants, the smooth muscle in the airway is going to tighten. The lymphocytes play an integral role when they produce a series of interleukins, IL-4, IL-5, and IL-13, and GM-CSF, which aid in communication with other cells, and then inflammation is going to occur. So IL-3 and IL-5 help eosinophils and basophils survive. IL-13 attributes to remodeling, fibrosis, and hyperplasia. Within the next several hours, the late phase is going to occur, and this is when eosinophils, basophils, neutrophils, and helper memory T cells all localize to the lungs. And then this is when you're going to have bronchoconstriction occur, and this bronchoconstriction is going to cause inflammation. Mast cells also play an essential role in bringing the late phase reactants to the inflamed sites. So what is IgE? IgE mediates the most common allergic reaction known as type 1 hypersensitivity. And this is an uncontrolled immune response in the environment, such as antigens in allergic diseases. IgE binds to two types of receptors, high affinity receptors and low affinity receptors. The high affinity receptors, where IgE binds more tightly, are located mostly on the basophils and mast cells. These are immune system blood cells that have granules containing chemicals that are involved in any allergic reaction. IgE binds to these cells in the presence of specific antigens, substances such as allergens that provoke an immune response. The binding sets off a chain reaction that causes the cells to release chemical immune mediators such as histamine, and these are responsible for the symptoms of an allergic reaction. So what are mast cells? Mast cells are a type of immune cell that plays a large role in the immune system. They're found throughout the body, but are especially near blood vessels and in the respiratory tract. So mast cells get their names from the ability to release protein antibody complexes, such commonly known as mast cells granules, when they sense that something harmful is in the body. Mast cells contain heparin, which allows them to form bonds with other cells, including neutrophils and platelets. So this allows mast cells to perform many essential functions, such as preventing microbes from entering tissue spaces and regulating inflammatory responses during injury or infection. The proteins that mast cells produce work together to increase blood flow and help remove bacteria from the bloodstream. These proteins also inhibit inflammation by preventing cytokines, such as TNF alpha. So mast cells play a key role in the inflammatory process. So when they're activated, mast cells can either selectively release or piecemeal degranulation or rapidly release anaphylactic degranulation, which causes inflammation. Mediators, or compounds that induce inflammation from storage granules into the local microenvironment. So mast cells is a type of white blood cell. It releases histamine in the following circumstances: when presented with an allergen such as IgE, and this is a typical allergy mechanism. So IgE has been released, and now we have histamine. This is the flood of immune cells to the foreign invader, and these cause the inflammation. This trigger, whatever it can be, dust, pollen, whatever, and the resulting histamine response can cause nasal tissues to inflame, creating pressure, itching, congestion, swelling, and breathing difficulties. The mast cells play a critical role in the pathogenesis of allergic asthma. Histamine is a central mediator released from mast cells through an allergic reaction, and histamine plays a role in airway obstruction via smooth muscle contraction, bronchial secretion, and airway mucosal edema. So what are leukotrienes and prostaglandins? Leukotrienes and prostaglandins in asthma are central in the asthmatic reaction. They are bronchoconstrictors that inhibit the mucociliary clearance, increase blood flow and permeability, and thereby induce edema, and they attract and activate leukocytes. Cytokines. Asthma is mediated by Th2 lymphocytes, which produce limited repertoire of cytokines, including interleukin 4, 5, 9, and 13. Now, although each of these cytokines has been implicated in asthma, IL-13 is now thought to be especially critical in asthma. So IL-13 is very important. It's presented with the eosinophilic lung inflammation, airway epithelial cell hypertrophy, goblet cell, mucus hypersecretion, fibrosis, and airway hyperresponsiveness. So remember, IL-13 is a big player in the inflammation and mucus secretions and everything that is constructing, interfering with that lung expansion, so you can't really breathe very well because you have too much mucus in there, you have too much inflammation, and so your lungs are not going to work very effectively. So what are T cells? A T lymphocyte is a lymphocyte of a type produced or processed by the thymus gland and it actively participates in the immune response. The T cell hypothesis of asthma, particularly chronic asthma, is based around the concept that the disease is driven and maintained by the persistence of specialized subset of chronically activated T memory cells. They're sensitized against an array of allergic, occupational, or viral antigens that home to the lung after appropriate antigen exposure or viral infection. So you're exposed to something and the T cells are activated. And a T cell is a type of a lymphocyte. And T cells are one of the most important white blood cells of the immune system and play a critical role in the adaptive immune responses. So what happens when a person has asthma? An asthma attack is any acute change in the asthma symptoms that interrupt the normal routine and requires either extra medication or some other intervention to improve so that the breathing can become normal again. When asthma worsens, there are three primary changes that take place in the lungs that make the airways smaller. So you're going to have increased mucus because as airways become irritated and inflamed, cells are going to produce more mucus. The thick mucus can clog up the airways of the lungs. The patient is going to experience inflammation and swelling. The airways of the lungs swell in response to whatever is causing the asthma attack, and then muscle tightening. As smooth muscles in the airway tighten in response to the asthma attack, the airways are going to become smaller. Asthma is a chronic lung disease, and like we talked about before, the narrowing and inflammation of the smaller airways, the bronchi and the bronchioles, really makes it more difficult for the patient to exchange air in and out. So the patient gets triggered by something in the environment. The bronchioles and the bronchi are going to get inflamed, mucus is going to be increased, and the patient is going to experience shortness of breath, wheezing, and respiratory acidosis. So let's review how air normally flows. So we inhale air with oxygen, and we exhale the carbon dioxide in the body. We have upper airways and lower airways. And then we have bronchioles that go to the alveoli sacs. Oxygen crosses over the capillary bed. Carbon dioxide goes out. Oxygen goes in. Smooth muscles surround the bronchioles. And the smooth muscles' job is to constrict and dilate. So constrict and dilate to allow all this airflow to happen. But if they are inflamed and there's a lot of mucus stuck in there, the muscles are not going to be able to constrict and dilate like they are supposed to. So with our patient who is experiencing an asthma attack, some asthma symptoms are going to be chest tightness. They're going to have a hard time breathing. Those bronchioles and bronchi are going to be swollen. And the lining has goblet cells, and goblet cells produce mucus. So goblet cells produce more and more mucus, and now everything is inflamed, so we have this obstruction in the bronchioles and the bronchi. This, of course, is going to lead to decreased airflow. The patient's going to be coughing, trying to get this mucus out, and we're going to hear wheezing because the air is going to be going through narrowed airways with the mucus, especially on expiration. So just remember that goblet cells, their function is to secrete mucus. So goblet cells also, they're compromising the epithelial lining of various organs. They're producing a large amount of glycoproteins and carbohydrates, but the most important function of the goblet cells is to secrete mucus. So what's going to happen to our patient and why are they going to experience respiratory acidosis? Well, we don't have air moving into the sacs. So we actually have air trapping in the sacs. And so when there's air trapping, the patient can't fully exhale. So when you can't inhale and exhale effectively, you're not going to have any gas exchange going on in those alveoli or over the capillary beds. So the carbon dioxide is going to stay in and the oxygen is not going to be able to get out. And carbon dioxide is acid. So our patient is going to be presenting with respiratory acidosis. We have a lot of causes for asthma. Some are just not known. Others, of course, can be environmental factors, smoke, pollen, pollution, perfumes, pet dander, pests, and sometimes patients have a hard time when they're out in cold and dry air. Some other common causes that patients might report will include mold, if they have a history of GERD, hormonal shifts, exercise, if they're on beta adrenergic blockers that are non-selective, we've talked about that, taking NSAIDs and aspirin. There are some early warning signs and symptoms that patients can become attuned to, usually 1 to 2 days before a full asthma attack. And the goal is for the patient to identify these early. Most patients have an action plan, and this is written by both the patient and the provider. You have different zones. So if you're in the green zone, you're okay. If you find yourself in the yellow zone, you can understand your asthma is getting worse, where you're coughing, you're wheezing, you feel some chest tightness. And then in the red zone, this is when the patient's in a full-blown attack. And some patients are given a peak flow meter device, and this is to help the patients not go into exacerbations of their asthma. So using this peak flow meter device, the patient exhales as hard as he can, and the peak flow meter tells him the airflow coming out. So here's a picture of a peak flow meter on the left so you can see what it looks like. Some signs and symptoms that you can educate your patients about if they have asthma to know that their asthma is getting worse can be coughing at night, or signs and symptoms of possibly getting a cold. They're not sleeping very well. They're wheezing when they're exercising or walking around, and they can't sleep and they're tired and they can be irritable. When the patient is in a full-blown asthma attack, they're going to complain of chest tightness. You're going to hear that wheezing. They're going to be able to feel that wheezing. They're going to have a cough that won't stop. They're going to have dyspnea. They feel like they can't exhale. They're going to have an increased expiratory rate because they're trying to get all of that carbon dioxide out. This can progress to bronchodilators that really don't work at this point. You might see some chest retraction, so their stomach is sucked in, the ribs are pulled out, their clavicle might be protruding, and no air is getting in. And of course, any turning blue, the cyanosis in their lips or fingers is also an important sign to assess for. Nursing interventions you should be doing for patients who are in an asthma attack. Of course, we want to get vital signs. We need a first vital sign for a baseline. We're going to try to keep the patient calm, help the patient to stay calm, keep them in a high Fowler's position to make breathing easier. We're going to be giving them short-acting bronchodilators. We're going to be giving them oxygen. Of course, assessing the lungs for wheezing before and after giving any medications, assessing for that cyanosis in the skin and the lips. We're going to be assessing for chest retractions. We're going to assess if the patient can speak. And we're going to assess the peak flow meter reading, and we're going to ask the patient what his best average is, if the patient is able to speak and give you that information. Here's another picture of a peak flow meter, and this is used to demonstrate how controlled the asthma is. The highest number reached over a period of time will be the person's personal best peak flow meter reading. And the patient is going to be doing these readings when the asthma is under control. We're going to have the patient exhale fully into the tube. There's a picture here on the left. We want our patients to measure once in the morning and once in the PM for 3 weeks. They're going to record the number before taking medications, and the highest number is the best peak flow meter reading. We want them to check it at the same time every night before their medications, and less than 80% of the personal best will lead to the use of their action plan that they have developed with their provider. There are 2 classes of medications we like to use with asthma. We have the bronchodilators and we have the anti-inflammatory medications. So over here on the left, there's some medication names and the description of what they do and how to use them. And you should know the chemical name, because on the NCLEX and your class tests are not going to be giving you the trade name. So make sure you understand the chemical name for these medications. Bronchodilators. Remember in previous lectures we talked about beta 1 and beta 2. Remember you have 1 heart and 2 lungs. So anytime we talk about beta 2, we're talking about the lungs. So the bronchodilators are going to dilate the airway for better airflow. We have beta agonists, you can see here under beta 2, anticholinergics, and then theophylline that we can use. But remember, we want an agonist, beta 2 agonist, because that affects the lungs, and that's going to dilate and open everything in the respiratory tract. So we have short-acting beta 2 agonists. Remember, we're talking about the lungs, and this is an inhaled route, an inhaler. It's a short-acting beta agonist, and this is used for fast relief. And this would be like an albuterol, you probably know from clinical, but it's not used for a daily treatment. We educate our patients not to take them more than 2 times per week. And then we also have long-acting beta. So Solumedrol, this is a long-acting corticosteroid. We never use a long-acting like a Solumedrol alone. We always use it in conjunction with a corticosteroid. So like Solumedrol or Symbicort, we're going to use them together. And we're not going to use this during an acute attack. This is for maintenance. This is long-term maintenance. So we have the short-acting and the long-acting. Short-acting is once or twice a week. Long-acting, we're going to give Symbicort with a corticosteroid like a Solumedrol. We never just give one without the other. And we're not going to use the long-acting during acute attack. We're going to use the short-acting during acute attack. So some side effects you need to educate your patients on with the beta agonist is that it might increase their heart rate, so they might become tachycardic, and it might make them feel a little jittery or nervous. So over here on the left, we have the drug, the mechanism, the uses, and then the adverse effects. So palpitations, headaches, tachycardia, flushing, maybe some anxiety or a dry mouth. Maybe some nasopharyngitis or a headache. So just know that when you're using a beta adrenergic agonist, you're going to have some other symptoms that the patients need to understand are expected side effects of these medications. We also use anticholinergic medications. We have short and long acting anticholinergic medications for asthma. Just remember with any anticholinergic medications, you're going to have a lot of hard time doing these four things. You really can't see, it might make your vision blurry, you can't pee, you can't spit, and you can't sh blank t. So it's kind of going to slow everything down. It's going to dry you up. It's going to dry you out, which is why your eyes might become a little drier, which might make your vision blurry. You can't really use the restroom, and you're not going to have a lot of extra secretions, so you probably can't spit. So just remember with anticholinergic medications, they're going to dry the patients out. So we need to educate them about this as well. So here's an example of an anticholinergic medication. Maybe people can't take the short-acting beta agonist. So ipratropium, this is used when people cannot take the beta agonist. But again, this is an anticholinergic medication. So review the last slide. It's going to slow everything down. They're not going to have a ton of secretions. But this is another medication that we use. It's an inhaler for patients who can't take a beta agonist, but this is a short-acting medication. Here's an example of a long-acting anticholinergic, tiotropium. Again, anticholinergics cause dry mouth and dry everything else. We can tell the patients that sugarless candy can help with the production of saliva, but this is a long-acting anticholinergic, tiotropium. And just remember, anticholinergics, you really need to educate your patients about what the side effects are going to be. Next, we have the theophylline, and it's not given too often these days, but it is a pill, and there's a risk of toxicity with this medication. So the dose is usually 10 to 20 micrograms per milliliter. The patients cannot have any caffeine while they take this medication because it can increase the risk for toxicity. And then with this medication, as patients have experienced GI distress, CNS stimulation, some arrhythmias, so some low blood pressure, and some acute kidney failure. So we don't like to give this a ton, but if we have to, we do. So this is another medication. Just remember, it's not inhaled. It is given in a pill form, and there's a risk for toxicity. We do give anti-inflammatories to our patients experiencing asthma attacks because, as we know, the inflammation is what causes the patient to be able to inhale oxygen and exhale carbon dioxide. So we give corticosteroids and we give leukotriene modifiers. So leukotriene receptor antagonists prevent leukotrienes from binding to their receptors. And then we have leukotriene synthesis inhibitors, which is going to block the ability for the formation of leukotrienes. So just know that there are many different brand names that you need to know on this slide. And these are anti-inflammatories. We got to get that inflammation down so we can open up those airways. So corticosteroids, leukotriene modifiers, and leukotriene synthesis inhibitors, because we do not want those leukotrienes to form in the first place because they are the reason that we have all of that inflammation in the respiratory tract. When we give our patients corticosteroids who have asthma, of course, the goal is to decrease inflammation. We can give it inhaled, IV, or PO. This is a long-term treatment and is not used in an exacerbation. So these medications, because it's a corticosteroid, can cause thrush. So the patients are going to be educated to use a spacer because this will decrease the risk of thrush. After they use the medication, we're going to educate them to gargle and rinse out their mouth. We're going to give this after a bronchodilator. So we're going to give the bronchodilator first to dilate those bronchioles. so that we can get the corticosteroids inside the bronchioles to decrease that inflammation. Another side effect of corticosteroids is that it can cause osteoporosis, and sometimes it can cause cataracts. So with corticosteroids, just know we do this to decrease inflammation, but we're not going to give the corticosteroid until after they're given a bronchodilator to dilate those bronchioles so that the steroid can get in there and then start decreasing the inflammation. With the inhaled corticosteroids, they have a potent glucocorticoid activity, and they work directly at the cellular level by reversing capillary permeability to reduce that inflammation. So this is why we give this after a bronchodilator. And the onset of these corticosteroids is gradual, so it can actually take up to several days or weeks for maximum benefit with this use. And metabolism is through the liver with a half-life of up to 24 hours. So again, local adverse effects of corticosteroids, dysphonia, again, that oral candiditis, the reflex cough, and possibly a bronchospasm. So we first use the bronchodilator, and then we give the corticosteroid, and then we educate the patient how to gargle and rinse their mouth out, to use a spacer when they're using this so that they decrease the risk of getting thrush. The leukotriene modifiers that we've talked about, so Singulair is an example. It's given in a pill form, it's taken orally, and this is going to block the leukotrienes because the leukotrienes cause smooth muscles to constrict, and they're going to increase the mucus production. So this is a long-term use. It's not for an acute attack. So if somebody's on Singulair, it's a pill they're going to take every day for a long period of time, and it's not going to be used in an acute attack. So some anti-inflammatories that we use. This medication we give sub-Q, and what it's going to do, it's going to block the walls of immunoglobulin IgE. Remember, IgE is really important with asthma patients. It's going to decrease the allergic reaction occurring in the lungs, and we're going to use this in patients where treatments aren't working or their asthma is very poorly controlled. This is long-acting. And it's usually a last resort. So we're going to try all the other medications we talked about before introducing a sub-Q anti-inflammatory medication. Cromolyn is another medication that you can use as an inhaler. It's like a nebulizer. And it's an NSAID. And so what it does is it stops mast cells from secreting histamine. Remember, histamine kind of kicks off that allergic reaction and brings all the other cells to the site. It's used for long term, and it's not for quick relief. And sometimes the patients might complain of a burning sensation in their nose or a bad taste in their mouth, itchy, watery eyes, but all of these medications, the side effects are usually temporary. They go away on their own. So Cromolyn is an inhaled like nebulizer, and again for long-term use, and it's not for quick relief.